So this is Dr. Gittleson's presentation, and I'm delighted to introduce him. Dr. Gittleson has earned his PhD and is a professor in the Department of International Health. He is a medical anthropologist who specializes in the use of qualitative and quantitative information to design, implement, and evaluate health and nutrition intervention programs. His research focuses on culture-based beliefs and behaviors regarding dietary patterns and how these factors influence the success or failure of dietary and lifestyle modification strategies. So join me in welcoming Dr. Gittleson.
All right, so thanks very much. The title of my talk is Environmental Interventions for Chronic Disease Prevention. And I'm going to be covering these four areas, conceptualizing the food environment very quickly, a little bit on how one might go about changing the food environment as an approach to chronic disease prevention. And then I'm going to talk about some of the work that I've been doing along the lines of trying to change the food environment, starting off with a project called Baltimore Healthy Stores, and then sort of what was the follow-up work that we did to that project after those initial successful small trials to try to change the food environment. So there's actually quite a large literature nowadays that associates features of the food environment with obesity and chronic disease. These are some of the more well-known articles, but basically what we see is that in areas with high access to supermarkets or full-service grocery stores, you see reduced rates or levels of obesity and chronic disease. In areas with high rates or with low rates of supermarkets but high rates of small convenience stores, restaurants, carry-out restaurants, those sorts of things, you see the reverse. So you see very high rates of obesity and chronic disease in those settings, and as just sort of the reverse of the other. So then how might one go about trying to change the food environment as a means of reducing or preventing chronic disease? One idea is to go about this is to change access to foods within retail food stores and prepared food sources by, for example, decreasing the availability of less healthy foods, or increasing the availability of more healthy foods, or changing the physical location of foods or doing renovations within stores to modify access that people have to those foods within those stores. And then there are also a series of things that one can do about the manipulation of price. So for example, raising the price of less healthy items, conversely lowering the price of healthier items. Another whole series of intervention approaches that are being considered are changing access to foods more generally or at a higher level within neighborhoods, for example, by building new supermarkets in places that do not have supermarkets, developing farmers markets, or improving transportation so that people especially in low-income areas who lack ready access to transportation to get to those healthier food sources, giving them access to that transportation. Another type of approach or way of changing the food environment is by changing the setting for the provision of information. Some people disagree with me when I say that that's a change to the food environment, but I argue that if you do something right where people are making their decisions about what foods they're going to eat for lunch that day, or what foods they're going to serve for their family for dinner that night, or maybe buy for their family's groceries for that week, that's a really good place to catch people, as opposed to doing it at a clinic setting or some other type of setting that might be hours, if not days, or longer removed from that point of decision. Then there have been a number of efforts that exist or have been being tried out at the policy level. These include things like setting standards for small stores especially, or requirements so that they have to stock certain kinds of foods, labeling of menus within restaurants. You've probably all heard about calorie labeling as an approach that's been tried in New York City. Rezoning is another process. As cities go through rezoning processes, they have the opportunity to create requirements for the kinds of stores or restrictions on stores that occur in these zones. And of course, you've probably heard about taxing or thought about taxing, and so something that's gaining increasing traction, though it's still not quite there yet, is taxes on sugar-sweetened beverages. Another strategy would be to think about working in multiple settings or institutions at the same time. So a lot of the obesity, chronic disease prevention work that's taken place in the past has focused on just schools or just food stores. But if you think about it, if you work in one particular sector or institution within a community, then as soon as people leave that institution, As soon as kids leave the school, then they're exposed to all the other issues in terms of availability of healthy food choices or all the other factors that influence their decision making. So the idea is to work in multiple institutions at the same time. Other approaches include things like improving food networks, improving the kinds of foods that distributors or wholesalers have to offer to local retailers, for example, improving local production of foods and the distribution of those foods to local areas, increasing the nutrient content of foods by working with manufacturers, or perhaps even changing the packaging of foods. So we're in Baltimore City now, so let's talk a bit about Baltimore City. So here's a map of Baltimore City, about 200 census tracts. Those are the, I don't know if you can see it too well, but those are the unit that you see there. There's about 200 census tracts. And all of the purple areas, and we are actually sitting right in the middle of one of those purple areas, are what we call food deserts. And food deserts are areas that have very low availability of supermarkets, and very high availability or very high rates of people who are at or below certain income levels, right? So a high number of people who are low income, but a very low availability of supermarkets or full-size food stores. So if you do have the chance to walk around outside the campus here, you might, if you go pretty much 1 or 2 blocks in any direction, you'll see a very different picture than maybe the place that you came from, and you'll see a lot of these. You see a lot of corner stores. So we don't have supermarkets, but for every supermarket we do have, we have 25 or 30 of these small corner stores. And this gives you an idea of the exterior. This is the interior. So there's not a high availability of healthy food options, as you might see in this particular setting. And in fact, about 20% of the corner stores are what we call behind the glass stores or closed stores. So in other words, you don't actually go in and are able to touch the food. You do your order through this little revolving window. You place your money there, you revolve it back to the person there. They put your order in there and revolve it back to you. So if you're thinking about doing nutrition education and telling people to read food labels, but if you don't have the opportunity to read food labels because you can't access the foods, that's a great limitation that we face here in Baltimore City, especially in the low-income areas of the city. So of course this has a lot of consequences. The first consequence is in terms of what's available in stores. And these are the results of by Manuel Franco, who was a doctoral student in the Department of Epidemiology. And he basically took a sample of census tracts in Baltimore City, and he and his student team walked those tracts and did a very detailed analysis of the kinds of food stores that were available. You can see that of the 176 retail food sources, only 16, so a little less than 10%, were supermarkets. And the majority were what he called corner stores, about 20% of those were behind the glass stores, and about a third or so were convenience stores like 7-Elevens, those sorts of things. And he created an index of the healthiness, took about 27, 30 different foods, and looked at the availability of those foods in those stores. And you can see that supermarkets have much higher scores, and the scores for these little tiny stores in terms of availability of healthy foods is much more limited. I'd have to say, though, that even within supermarkets, this isn't so great, right? If you go to some of the larger supermarkets, you'd have a score of 27 or whatever the maximum possible score would be. Most of those supermarkets are in the outskirts or the suburbs of Baltimore City. Most of the supermarkets within city limits have these, they're a supermarket, but they have a more limited range in terms of availability of foods than those outer food stores. So, of course, when we are going about developing our interventions or our programs to try to modify the food environment, we talk to people. I'm an anthropologist by training, although I have a background in training in nutrition as well. And but we never start without talking to people. And I'm going to present a little bit of results from the work that we did in Baltimore, but I want to say that actually I've done this work in Pacific Islander settings. I've done this work with American Indians, with First Nations, with the Inuit in the Arctic, many different settings, and I hear almost identical kinds of comments as what I'm about to present to you right here. So, from store customers, from community members, I hear, I would love to buy or eat healthy foods, but they are too expensive, not available in the stores that I shop in, or they are of poor quality. in the stores that I shop in. And I hear this in Baltimore, but I hear it many different places. So maybe not a surprise. Maybe if you've worked in low-income settings and you know about the lesser availability of healthy food, I should say lesser availability of affordable healthy food choices, that this may be a common kind of occurrence or a finding that you would expect. But it's important also to talk to the providers of those foods, the retailers. And when you talk to store owners and managers, what you hear is an interesting contrast. I'd love to stock healthy foods, but nobody buys them. Or the last time I stocked, and you can fill in the blank, low-fat milk, whole wheat bread, whatever. It just sat on the shelves, nobody bought it, and I lost money. And this is also a really common finding that we've had in many different settings, which is that there's kind of an impasse, if you will. There is a difference in perception in some regards that the suppliers don't see the demand. The people who are the demanders, the consumers, don't see that there's a supply there. And so we've actually found that in our work to try to change the food environment, we have to negotiate, sort of cut a deal between both parties. We have to convince the suppliers of foods that if you stock healthy foods, we will work hard to increase demand. And we have to convince community members that if you demand those foods, if you request, if you purchase those foods, we will make sure that those will work with the store owners, the suppliers, to make sure that those foods are there. So that's actually a large part of what we do. I want to give an example of such a project called Baltimore Healthy Stores, and the goals of this project were to increase availability and access to healthy foods for especially low-income residents of Baltimore City, to promote these foods at the point of purchase, and to work in collaboration with community agencies, the City of Baltimore, and other local food sources. And I do a lot of stuff with boxes and arrows and models and that sort of thing. It's inescapable for me. So I apologize for this one, but this represents how I tend to think about the food environment, working at multiple levels, kind of a meta level about the food supply, the information environment, kind of a institutional level within the community, including schools, rec centers, other community venues, restaurants, retail food stores. These have an effect at a interpersonal level, at households, at the peer level. These can influence things at a individual level in terms of cognitive processes, knowledge, perceptions, which will then eventually influence diet and chronic disease. This particular project focused at the retail food store level. It thought by changing availability and doing point of purchase promotions at the retail store level, we could improve food preparation and purchasing at the household level. This would then affect individual psychosocial characteristics in adults. The focus was primarily on adults. And then this would influence diet. And we did not assess for this particular project obesity as an outcome. So here's again another picture of Baltimore City, and we worked in East and West Baltimore. So you're sitting kind of smack dab in the middle of East Baltimore right now. And East Baltimore was our intervention area, West Baltimore was our comparison area. We worked in about 8 or 9 food stores, a couple supermarkets, 6 or 7 small corner stores in each area. By the way, this is perhaps only a 10% sample of all the corner stores in each area, or even less. We also had a consumer sample that we looked at in each area. We started off doing a lot of formative work, a lot of qualitative data collection to help us plan the program. We also did a lot of what we call community workshops. A lot of the work that we do, it involves a community engagement, participatory process, and that's how the materials, the strategies, the foods for promotion, and so forth are decided upon. And out of that process came a program that was conducted in 5 phases, each phase roughly 2 months long. And just to give you an idea of what some of the materials would look like, in the snack phase there would be posters and so forth promoting those snacks. There would be educational displays, again promoting healthier snacks, flyers, coupons, little giveaways. We would work with the stores to increase the availability of healthier snacks. We would do interactive sessions in the stores, again promoting whatever foods were being promoted for that particular phase. Again, the goal is to increase demand for those foods. So both at supermarkets and in small corner stores. And something that I didn't emphasize before which is a particular feature of the Baltimore City food environment, which is that about 80% of the small store owners in Baltimore City are Korean American. And we found that there were, in fact, some great cultural and communication differences and barriers between certainly some of the Korean American store owners and the predominantly African American community that they served. And so we actually found that we had to develop a whole component of the intervention that was directed at the Korean American store owners in Korean. And that was delivered by a Korean doctoral student. To give you some, so we evaluated the program. Here, if you come here to Hopkins, you'll see that we spent a lot of time thinking about evaluation and thinking very carefully. I want to point out a couple of features of evaluation that you may or may not be familiar with. One is that we did a lot of process evaluation. Process evaluation is looking at how programs are implemented, right? How well did you implement a program according to plan or your set standards? We also did impact and looked at the impact of the program at the store level. And we also looked at the impact of the program at the individual consumer level. Just to present a little bit of data, this is looking at the stores from pre to post in terms of change in stocking. And what we see is that let's see if this is, oh, it is. So stocking score, that's this area right here. These are our intervention stores. These are our comparison stores. From a sample of about 10 promoted foods, how many of them were stocking them at baseline, intervention versus comparison? No significant difference. Immediately post the promotional phase, we saw a higher number of those foods being stocked in the intervention versus the comparison stores. And then at 6 months post-intervention, so that's after completion of the whole project, there still continued to be higher stocks of those healthier foods in the intervention stores than the comparison stores. And of course, from a store perspective, you're not just interested in showing can you get the stores to stock the foods, but how does it affect sales? And so we looked at impact on sales, and we saw essentially the same results. Immediately post-phase and 6 months post-intervention, we saw increased sales of the foods that were being promoted. So we thought, we felt good about that. We thought that was a good sign and would possibly lead to some increased adoption of this kind of intervention by local stores. We also looked at the impact of the intervention on consumers. And after adjustment for a variety of different factors, we saw a significant impact of the intervention on food preparation and frequency of purchase of promoted foods. So that was all good news. This kind of work, I've mentioned that we worked in many different settings. And this kind of work has been, well, I shouldn't say duplicated, because the Baltimore Healthy Stores work came, actually, it was sort of second or third in the ranking of the work. But we've done this kind of work in many different settings, with Saginaw Chippewa in Michigan, with the Inuit and Nunavut in the Canadian Arctic, Baltimore Healthy Stores, Jawapane-Wanakino-Magawan, if you can say that after the lecture. You may get this free sweatshirt, I don't know, which was with First Nations in Canada. Another project in Baltimore, Dene Healthy Stores, which is with Navajo, Healthy Foods Hawaii, which was with Native Hawaiians. Another project which is with church-based interventions, I'll talk about later, in Baltimore City, working with the White Mountain and San Carlos Apache reservations, working with the Marshallese, and this is also related to the Navajo project. So we've done a number of these projects over the past decade or so. And apologize for this complicated slide, but basically what this slide shows is for all of the projects that we've done the impact analyses, what are the significant findings? And basically what we see is in terms of impact on consumer psychosocial factors, and so these are all studies where we had intervention and comparison samples that we looked at pre-post and compared the change from pre to post in intervention versus comparison. And so in all of these studies, we saw that they were all successful in impacting some consumer psychosocial factors, such as knowledge or intentions, behavioral intentions. We saw that they were pretty much all able to impact on frequency of purchase of healthier foods. So we saw increased frequency of purchase of healthier foods. Where we've done the analysis in terms of dietary assessment, we were able to show increased gram consumption or increased healthy eating index scores among consumers who were part of the intervention sample. and where we've done the assessment in terms of the store's stocking and sales, we are able to see significant impacts at the store level themselves. So this is sort of the work of the past 10 years or so, but in the past couple of years, we've sort of been thinking about, okay, so what was the next step? Where do we proceed from these sort of successful small trials? And I want to describe a little bit of where we've proceeded since then. So one thing that we've done is to continue to refine the intervention, to make it better. And I want to give the example of a project we're just concluding now called Baltimore Healthy Eating Zones. The goal was to develop, implement, and evaluate an environmental program for low-income African American children by creating healthy eating zones in and around recreation centers in Baltimore City. And we wanted to see if the program would improve children's psychosocial factors, purchasing of healthy foods, if we could change the food environment, and if we could improve food consumption. And ultimately, we hoped, although we weren't powered to show this, we hoped that we could show an impact on obesity. So back to our conceptual framework, should be familiar now. So yes, we did work in retail food stores as part of this intervention. We also did hope that that work in the retail food stores would affect household food preparation and purchasing. We also thought that those sorts of things would affect psychosocial factors at the individual level. A difference, though, is that this project was about adults and children, and we thought that these things would influence diet, so that's all pretty standard except for the addition of children. But where we varied from previous is we included additional institutions. So we were working not with schools but with recreation centers, and so a lot of the intervention took place there. We also brought in restaurants, actually carryouts. In low-income areas of Baltimore City, you'll see, well, you'll probably see a few fast food restaurants, but in fact they are the minority. Most of the prepared food sources in low-income areas are individually run carry-out restaurants. And so we've worked in some of those carry-out restaurants. We also brought in a peer component. We trained 1 to 2 peer mentors or youth peer educators in each recreation center. And we hoped that for this particular trial, we would be able to see an impact on obesity. So again, this project was about creation of healthy eating zones. We worked to increase availability of healthy food options, both in local food stores around those recreation centers and within the recreation centers themselves. We did a lot of point-of-purchase signage, interactive sessions, all of these things that I've previously discussed as part of Baltimore Healthy Stores. But a couple of additional components besides the new venue with recreation centers and working with prepared food sources was that we involved, again, peer educators, and we did a recreation center staff training so that they would be engaged and could help sustain the program. Our evaluation, we have 242 youth caregiver dyads, so a youth in the age range of 10 to 14 years, plus their primary adult caregiver. We did a lot of assessments, including a food frequency questionnaire. We did assessments with recreation center staff, and we looked at environmental changes in the various food sources that were around there. And of course, we did a fair amount of process evaluation. We recycled a lot of the materials that were used as part of Baltimore Healthy Stores, but in fact, that was the stuff that was aimed at adults, and the materials that were aimed at children, in fact, were developed by a local community organization called Kids on the Hill, which emphasizes social activism through media training. And so they teach young people how to develop materials, and these are some of the materials, or at least drafts of the materials that they developed. I think they're a lot more hip than anything that I or my team could have developed. So there was, again, interactive activities in food stores, but there was also a lot of interactive activities in the recreation centers themselves and involved a lot of cooking. We found that a lot of the kids actually do a fair amount of food preparation. Now, they aren't whipping together gourmet meals. They're heating up things in the microwave. They're doing different kinds of simple assembly and preparation, but we made this part of the intervention. I already said that. Am I going backwards? So where we are is, in fact, we're a little bit further than this. We've completed, obviously, the baseline data collection. The intervention is completed. And we're at about, actually, about 66 to 67% complete with the post-intervention data collection. So I don't have results to show you today. What I do have to show you is that a couple of things. We did assess the impact of the intervention or exposure to the intervention. We showed the kids and their caregivers sample material. Have you seen this before? Did you attend one of the interactive sessions? And what we see is, and this is a challenge for doing community-based studies, is that, as we would hope, the intervention kids, the kids who went to intervention recreation centers, had higher exposure scores than the control group, and they were significant. But the other thing to note is that the control group had exposure. In other words, we had no way of building brick walls to keep people who would normally go from one recreation center to keep them from going to another recreation center or stopping them from shopping at another carry-out that's out of their neighborhood. So there was actually a fair amount of, I guess you could call it contamination from a research study perspective that occurred. And we looked at this in a couple of different ways. So this first one is about exposure to materials and activities. The second one is about how frequently they went to our intervention recreation centers or to our intervention stores. And you can see that although, again, the intervention group is higher, you still see a significant number of people from the comparison group who go to the intervention recreation centers and stores. And so what we've had to do, in fact, is create overall exposure scores, and we're going to look at the data in a couple of different ways. One is by intervention and comparison, but another way is by just low or high exposure to our intervention materials. And maybe stick around or come here next year, and I should have some data to show you in terms of the impact of this trial. Another trial that I want to talk to you about, which is going on right now, is a program called Baltimore Healthy Carryouts. And as I mentioned before, in fact, about half of the food sources in low-income areas of Baltimore City are prepared food sources. About half or more of calories consumed come from prepared food sources. So it's all well and good to change what's available in retail food sources like supermarkets and corner stores. But if people are buying a lot of their daily food from these types of sources, you should think about working in prepared food sources as well. So if you take your walk around the community, you will probably see a lot of these corner stores and in this case carryouts. And this is what a lot of them look like on the interior. They do a lot of deep frying. Okay, there's not much charcoal grilling and that sort of thing going on. A similar sort of setup with corner stores, frequently with these sort of rotating windows. The signage is often very rudimentary, and I think if you'd be hard-pressed to find some item on this particular menu that you would say would be healthy. Lake trout is not from a lake. It's not trout. It sounds very healthy, I'm sure, but it's some kind of cod, I believe, batter and deep fried, and so whatever positive ingredients, it's like a fillet of fish sandwich at McDonald's or something. Whatever positive, healthy ingredients that were in it, it's been cooked out of it, I suspect, by the time it reaches someone's plate. So carryouts represent a real challenge in this setting. So the aims of Baltimore Healthy Carryouts was to do a pilot trial, to do formative research, to help plan the program, to develop and test interventions and pilot instruments. And so again, taking our model, this involves restaurants, which we think will affect household food purchasing and preparation, which we think will hopefully affect psychosocial factors in adults. The focus is in adults for this small pilot trial. And we think that will affect diet at the individual level. We've done a lot of surveying of the setting. We've gone throughout Baltimore City, East and West Baltimore. And what you can see is the primary kind of restaurant that you see are carryouts, about 70%. Corner stores with carryouts is about 16%. And then fast food restaurants, less than 10%. Sit-down restaurants, about 5% or less. So really, it's carryouts are king. Carryouts, if you want to work in the prepared food source environment, that's where you need to focus a lot of your attention. So the intervention actually started about a week ago. The first phase is changing the physical environment and menu labeling in carryout. So we've given them each a new menu, and I'll show you what those look like in a minute. And the menuing is about identifying healthier options. There usually were a couple of things that could be described as healthier. I'm not saying healthy, but healthier. Phase 2 of the program, starting in about 2 months, will be about introducing healthier sides and beverages. Phase 3 is going to take it a step further and work on pricing manipulation and healthy combos and those sorts of things. This is an example of one of the new menus that was developed, and you might say, Joel, looks great. What's that leaf all about? The leaf is the healthier option. Why didn't you just say healthier? Can anyone guess why we didn't say healthier or low fat or something like that? Total turnoff, right? So if you say a food is healthy, that conveys in this setting tasteless, rabbit food or what have you. The kind of terms that convey quality and healthiness actually we found in our formative work was the word fresh. Now, we also have some signage that helps elsewhere that identifies what we think are what we mean by fresh. And then what we've done is we've highlighted some of the options that we think were better. Now, I'm sure you can look at some of these and say, well, that's not so good. It's better, okay? So we have some work to go. And as we proceed, we'll be working with them to change so these are what's in their existing menus that could be labeled healthier. But we're hoping over time, as we work with them to introduce side dishes and ideally entrees and so forth, we'll increase the number of leaves on their menus, and we will redo the menus for them. Many of these small carryouts also run takeout. I mean, it's a takeout business, so they circulate the flyers, so we've done similar things with flyers as well as the menu board that exists in the carryout. And sometimes how are we doing our evaluation? Actually, we've given them, they have these little boxes, and they write down the order and they slip it in the little box after it's completed. And so basically we have too much information on sales of foods at each of these carryouts every day, every sale. Some of them do, hundreds, if not thousands, of these little things in a week or two. And so we're kind of at an overload point which we're going to have to deal with. But at least they're giving us the data, and we will be able to track, and we're writing down their own glossary, because they don't write down chicken sandwich. They write CS or something like that. We're writing down their code, so we'll be able to interpret and figure out what foods change in terms of their proportion of sales. And also we'll be able to look at actually dollar sales, because we want to be able to show these carryouts that we did not adversely affect their total sales. Next steps. So I talked about a lot of work that we've done to refine the intervention, but another thing that we've done or are working on are interventions to impact actually on health outcomes, and also to expand our previous work to additional communities. I want to briefly introduce a project called OPrevent. OPrevent is actually an acronym. It stands for Obesity Prevention Research and Evaluation of Intervention Effectiveness in Native North Americans. That's kind of a lot to say, so we say OPrevent. And in fact, the study team is now starting to say OP, because even OPrevent is too long. But it's a program that takes this multi-institutional approach. It combines communications, family, school, food store, and worksite components for obesity and diabetes prevention in American Indian communities. We're working with 2 communities in Michigan and 4 communities in New Mexico. And again, the project will have 4 programs: a family/school program for families of children in grades 2 through 6, a store program that uses a lot of the approaches that we've talked about already, a worksite program that will focus especially on increasing physical activity, and a communications program that will work at the community level. Just a few words about the family/school program. It will focus on healthy eating, physical activity. It will use a lot of storytelling. There'll be components of that program that go home to families. The store component, really, that's what I've talked about before. The worksite program, emphasis on physical activity, and probably pedometer challenges will be part of what we do for that. But the big idea behind this intervention is that you have reinforcing programs that happen at the same time. Children learn about healthy snacks as part of the family program. They take that message home. You might call it the nag factor. In the literature, it's actually referred to as the nag factor. They encourage their parents to purchase healthier snacks. The adults then go to the stores. They see signage for healthy snacks. They may do a taste test. So that's another encouragement that happens at the store program. And or adult workers may hear about healthy snacks on the job as part of the worksite program. So all of these things happening at the same time to reinforce key messages to improve availability of healthier options and hopefully to change behavior. We're going to evaluate it every which way but loose, including a lot of process indicators, multiple impact indicators, including psychosocial, behavioral in terms of diet and physical activity, and health outcomes, especially BMI. The next step that we're taking on the basis of this work that we did earlier to try to change the food environment is dissemination. How can we best disseminate this approach or these approaches that we've tested out in different settings? And recently, the Center for Disease Control, who support a center at the University of North Carolina called the Center of Excellence for Training and Research Translation, adopted Baltimore Healthy Stores as one of their research-tested or evidence-based interventions. And so they are providing that program, its materials and so forth, to city and state health departments through their own training activities. So I was really pleased to see that this particular program is now being disseminated more widely than I would ever be able to do it. We can talk about scaling up as another approach or direction to take, and scaling up perhaps through policy change. Now, I'm not a policy expert, so I'm kind of feeling I'm not even sure I'm a policy beginner. I mean, I'm a rank beginner in terms of working in policy. But the way that I see it is the only way that things will ultimately become sustainable and expand to a higher level than I am able to do in my, I'd have to say, micro community or small community studies, is to try to make things happen at the policy level. So we implemented a small study called Baltimore Corner Store Criteria Program. The idea was to, as well as our own, investigate the experiences of other small store intervention programs, develop a list of small store guidelines, and to incorporate this list into the city's rezoning plans. So you've come at an opportune, or you will come, hopefully, at an opportune time for the city of Baltimore. They're going through a rezoning plan. It doesn't happen that often, at least not in Baltimore. This is the first time in about 30 or 40 years they're doing a comprehensive rezoning of the city. It's called Transform Baltimore. We developed a report. The report is under review by the Departments of Health and Planning for the city, and it makes a series of recommendations on how we can establish and enforce and incentivize a series of regulations to increase the availability of healthy food options in small corner stores. So I was only able to work in 10, maybe 20 or so small stores, but there are thousands, or at least over 1,000 of these small stores in Baltimore City, much more than I'll ever be able to work with. The only way to reach them probably is through some sort of comprehensive policy work. These are some examples of some of the recommendations that we came up with. I'm not going to go into these in any great detail, but the idea behind these is to create a series of guidelines for stores to follow. Different, you might say, behavioral guidelines include stocking of certain kinds of healthy foods. It includes how you set up the store and so forth. And then as the store achieves certain levels, they get maybe some tax benefit or some other kinds of benefits. And there's a monitoring process that would be laid out by the Baltimore City Health Department. And of course, there's, as well as the carrot, there would be a stick component as well. So in conclusion, the healthy stores approaches that we've described to you have been successful in changing the food environment in many different settings. I'd have to say that I've worked exclusively in low-income ethnic minority settings. I'm not certain whether it's necessary or needed in other more affluent kinds of settings. I think it's also important to think about addressing both supply and demand issues. We learned that lesson pretty early on. It's not just about educating consumers so that they will somehow magically eat or select healthier foods. You have to make sure the supply is there, access is there, and that means availability and cost. It has to be affordable. And what we found also is that it's helpful and can strengthen the impact or increase the impact of your program if you work in multiple institutions, not just food stores. Food stores, recreation centers, carry-out restaurants, or schools, or additional institutions. And I think the lesson that I'm learning over the past 10 years is probably the importance of thinking beyond the initial trials. My job at least does not end here with this little trial, but really thinking about the next steps, where these things can go. I want to acknowledge many, so this is not all my work. I've worked with many other faculty on these projects over the years. These are some of them. For every faculty I've worked with 5 to 20 students at least who have been involved in these projects. And many of these projects actually have opportunities for you if you come as a student here to work with me. I do a lot of work with students, is doctoral dissertations, work study, other kinds of opportunities. So if you do come here, please look me up if this is something of interest to you. And the funding comes from a lot of different settings, a lot of it from the USDA, but also from other foundations such as the American Diabetes Association and the Robert Wood Johnson Foundation. Thank you very much. So I'm ready to respond to any questions, comments.
In your carry-out stores or carry-out food places, how do you get compliance with them? I mean, obviously they're worried about, they don't have a lot of money. They're not making big bucks in those stores. So how did you work with them to say this is a good thing for both you and your clients?
So the question is, how do we get carry-out stores, and perhaps you mean corner stores as well, retail as well as prepared food sources, how do we get them to participate? And how do we make that happen? There's no secret magic bullet. We use a variety of different techniques. As you saw before, about 80% of the corner store owners are Korean American, and about 50 to 60% of the carry-out store owners are Korean American. Having a Korean American student work with me was essential, and I seemed to attract Korean American students. And so maybe it's because of these projects, and I'm on to my 4th doctoral student who, actually they're not Korean American, I mean they haven't officially living here yet, they're not citizens, but anyways they're Korean. And so that makes a big difference. We work with local agencies. So for example, the Korean American retail community is represented by the Korean American Grocers and Retailers Organization. It's a national, actually it's an international organization. They have a branch here in Baltimore City. We have to get their support to do that. So we would bring letters from them of support and so forth. We would do orientations through that institution. There's also incentivization that we offer for the small store owners themselves. So one form of incentivization is we will promote you. We will try to increase your business. But many of these small stores have had negative experience in trying to stock healthier foods, and they'll say, I've done that before, it didn't work, I lost money, I'm not going to try it. So in some cases, we've provided a small gift card for them to use at their local wholesaler, $25, $50, something like that, so that they can purchase a starter stock, whatever the food is that we're trying to promote for each phase. And that's usually enough for them to stock 10, 20 units of the food, so that then they can, hopefully with our excellent point of purchase promotion, those sales of those foods will increase. So that's so we use these variety of different ways. Yes?
In one of your slides, you had the chart displaying an evaluation of the results, and you had question marks. I'm just wondering what the question marks were.
There was a question about, so the question is about one of our evaluation results with question mark. I'm trying to remember, so which slide was that? Oh, the question marks. So the question is, what were the question marks on my summary table that presented the results of multiple studies? Question marks mean we've collected the data, but we haven't analyzed it yet. So stay tuned. Come to Hopkins, and I will present a future presentation where at least some of those question marks will be answered. Yes, ma'am.
Kind of similar to the first question. In those initial community workshops that you had talking about how to develop a program, were there other food and nutrition, of saying something to the effect of, well, that's important, that's fine, but this is really what's going on in my community. This is really, I think this is more significant. Was there any dialogue around other sorts of projects that came out of those community workshops?
So the question is, when we do the community workshops, do other topics besides the immediate issues of concern that I have related to food and improving the food environment, do those other topics come up? And so the answer is yes, for sure. The way that we have run the workshops is that actually the first thing that happens is not Joel stands up there and talks about X, Y, and Z. The first thing that happens is actually each participant in the workshop has a chance to speak. You almost think of it as a talking circle, and they take as much time as they want, and they talk about the issues of concern that they have. I sometimes limit it to more health-related stuff, but a lot of things are related to health. Even social problems in the household, those are often very related to health. So we actually, that's a key important thing that we do, because it gets people talking. So that lasts anywhere from, I guess if people are not very talkative, maybe half an hour, but I've had it last more than 2 hours of people sharing the things that they think are important. And we don't just have them talk, we write it down. So we write it down on flip charts, we put the flip charts up on the walls, and so all of these things are themes that we come back to and we think about, and we found that this is a really important first step in this kind of community workshop process. So thank you, it's a good question. Yes?
You mentioned that you personally aren't as focused on policy in the higher up levels, but I'm wondering how did you decide where to intervene in this issue in many of your projects? For example, in the Marshall Islands project, you would think the issue of making healthy food available on the islands would be a more policy level issue. So is the work there similarly at the community level also, or do they vary per region?
So the question is about how do I get involved with policy, and how do I make decisions about the degree or the extent to which I involve policy? And you asked specifically in the Marshall Islands as a case, it would seem that you would want to think a lot about policy in that setting. So the first thing I'd say is I'm very interested in policy, and I've come to recognize the importance of policy, and I'm trying to get more involved in policy. Point two, though, is I don't have much formal training. What has happened to me is because of these projects, I get invited now more than I used to talk about such and such and to be on various groups and working groups and so forth. And I began to, and this is happening over the past 5 or 6 years especially, where I'm invited to testify on something or contribute or be part. So Baltimore City has a obesity task force. It has a task force on the food environment. Baltimore City now has a food czar who is involved in trying to change or improve the food environment in the city. And so I've become engaged with those processes. And I guess you'd have to say I've been feeling my way or learning my way as I go along. Every setting is a little bit different. In some settings, so in Baltimore, I'm able to be quite engaged to a certain degree with the policy situation. In the Marshall Islands, I haven't been there for a number of years. And so the work there, the emphasis was not so much on policy, but on capacity building. Not to say that we don't do a lot of capacity building in many different settings, we do, but capacity building of key members of the Ministry of Health and Environment so that they then, honestly, the best people to work in policy are the people from that community or that setting who are going to be there, not Joel, who comes by once every year or two to try to affect policy. So to do capacity building in that setting. So in some settings, I'm more directly involved. In other settings, I'm a anxious cheerleader. Other questions? Yes.
So you said there's 10 items that you looked at for comparing what stores are still offering, is that correct?
Right.
What were those 10 items?
So the question is, what 10, and this will have to be the last questions because I've gotten the nod from our organizer here, but the question was, what 10 items, what 10 foods were they that we looked at? And I'm going to only be able to remember a few of them, but whole wheat bread, low-fat milk, low-sugar, high-fiber cereals, healthier alternative snacks like baked chips, fruits, vegetables, your water. Now you're taxing my memory here. So I mean, it was those things for sure, and a few other ones as well. And those again were decided upon by the community workshop process. Okay, so please feel free to come speak with me after the talk, and thank you very much.